Hello, and thanks for checking out FirstcallID, Approach to Fever and Illness After Traveling Abroad, or Illness After Travel. My name is Paul Bunce, and I'm an ID physician. Today we'll be spending about the next 15 minutes or so going over some of the key aspects of an ID consultation with respect to illness after travel. If you haven't already done so, please check out our first session on how to do an infectious diseases consultation, which covers a lot of the basics of ID consultations in general, whereas this session really focuses on the specifics of the assessment of the return traveler. Lastly, before we move on, just a quick comment that this content is for educational purposes only. Please refer to current guidelines and professional judgment in clinical practice. Here are a few points that I also want to add to preface the session here. The first is that this session is tailored for North American clinicians who are evaluating return travelers from abroad. The second is that you don't need to be a tropical medicine or geography expert. Just employing a structured approach to the history and assessment can often provide an adequate foundation for your assessment of these patients. The third is to keep in mind both travel and non-travel related conditions, and also consider infectious and non-infectious causes for your patients' symptoms when you're seeing them after travel. It's not always the travel. So here are the key points that we want you to include in your evaluation of traveler or return traveler with illness. The first is an accurate and well-documented travel history, including the timing and locations. Did the patient seek pre-travel advice? Did they receive vaccines? Were they prescribed prophylaxis? And were they adherent? In terms of their travel-related exposures, we want to keep in mind vector-borne illnesses, environmental exposures, as well as human encounters and human exposures. When we're evaluating their symptoms, most commonly and most notably is fever and what was the pattern of fever. Have they developed GI symptoms, any cutaneous lesions or rashes, respiratory symptoms, arthralgias and arthritis, and rarely neurologic symptoms? We'll provide a detailed and comprehensive physical examination with a few things that we'll pay particular attention to in the return traveler. Investigations we'll consider, so routine evaluation is always included. If relevant or if there's any potential exposure to malaria, we'll include seromalaria testing, blood cultures, additional serologic testing based on their travel locations as well as their symptoms, and if there's GI symptoms, we'll include stool studies. And from this, we'll provide recommendations on empiric management if indicated, any advice on disposition. Does the patient need to be admitted or can they be followed as an outpatient? Should the patient be placed on specific isolation precautions? And should public health be notified? So the travel history and timing is the single most important part of your evaluation when you're seeing someone who's developed illness after travel. The one line I used to be told is if you've just asked, have you traveled recently, you'll miss the key details. So you always want to ask where they were, when they were there, and what they did. So locations and dates. Also, if they've traveled, when did they leave the endemic region, and when did they arrive back home, and when did their symptoms develop in accordance to their travel? Because sometimes people are traveling for more than 1 or 2 days. So symptom onset relative to the travel dates. What was the purpose of the travel? And did they stay in urban versus rural situations? Again, one of the lines I used to be told was, did you travel first class or no class? Again, getting a sense of their possible exposures. Did they seek pre-travel counseling and get pre-travel advice? Did they get immunizations that were relevant to their travel destination? Were they prescribed prophylaxis, and were they adherent? And this is particularly important with certain types of malaria prophylaxis, which are much less effective if doses are missed. And a few words about VFR travelers, or travelers who are visiting friends and relatives. This is not a pejorative term, it's simply the purpose of their travel. These are often individuals who grew up in an endemic region and have been living outside of that region for some time and returning home to visit friends and relatives. And this is a high-risk group for certain travel-related illness because they often do skip travel-related advice and pre-travel consultation. And also when they're traveling to certain areas, they might not take the same precautions as someone who is not familiar with that region. And in certain regions where there's malaria endemic, patients who were previously partially immune to malaria may have lost that immune protection and may be more at risk of severe disease. We'll take a detailed exposure histories, putting into big categories, so vector-borne exposures, so animals and insects, environmental exposures, water, both in terms of what do they drink, what are they exposed to, and food intake, I often say everyone will drink a little bit of the water and eat some local food, but you do want to get a sense of how extensive their exposures were. And often ask, what was the most exotic thing you've eaten, or what were some exotic things you might have experienced? We'll also ask about human exposures, so sexual encounters, any sick contacts, and healthcare exposures. Again, specifically asking about animal exposures. Did you touch any animals? Were you in contact with any animals, any bites? Or even did you see any wild animals or wildlife while you were traveling? We'll also ask about the types of activities they pursued while they were traveling. You'll want to obtain a detailed symptom history. If there is a fever, was it a subjective or documented fever? What is the pattern of fever? Any gastrointestinal symptoms? Any skin manifestations of illness, rash or other ulcers, bites, that type of thing. Respiratory symptoms, neurologic symptoms, and any arthritis or arthralgias. Our physical examination, so will be a complete physical examination. We'll comment on the patient's fever and pattern of fever for what we're observing, presence of jaundice, toxic appearance, and any alterations in their level of consciousness. A detailed and comprehensive skin examination, looking for any rash, examine closely for any eschar that would be related to a previous bite, any observable bites, and any ulcerations. Lymph node examination, pulmonary examination, again screening for pulmonary or respiratory illnesses, examining for hepatosplenomegaly on our abdominal examination. Our neurologic examination, in addition to LOC, we'll examine for any focal neurologic deficits, especially if there are neurologic complaints, and any meningeal signs. We'll evaluate for any evidence of arthritis versus arthralgia, so actual visibly inflamed joints versus just painful or tender joints. It's often sufficient to start with just routine evaluations, so CBC, regular blood work, chemistries, liver enzymes, and often a chest x-ray. If a patient's traveled to a malaria endemic region, we'll want to do serial malaria testing. Usually we'll require 3 tests at least 12 hours apart, and depending on where you're working, they'll have different types of assays to perform. Blood cultures, if there's concern for a bacteremia. We'll consider additional serologic testing or PCR testing, although I find that these often don't need to be performed in the overnight period. I think when you've had time to completely evaluate the patient, you can get a sense of how likely these particular infections are, and kind of batch your serologic testing afterwards. These tests often take some time to come back and often don't have any specific therapies, and so they might not be required in the initial overnight assessment. We'll consider stool studies as well if there's any gastrointestinal symptoms. From this, we'll provide our impression and recommendations. We'll offer advice on empiric management if it's indicated, usually a severely ill or septic patient. Empiric therapy for malaria, if there's a delay in obtaining the diagnostic test, is something you can also consider. We'll provide advice on disposition, and this will depend on how sick the person is, what their reliability is for follow-up, and also what options you have for follow-up. Some institutions have rapid access to clinics who developed illness after travel, often within 1 or 2 days. And so depending on the patient's status and ability to follow up with them, you may consider safe discharge home versus observation in hospital. We'll consider isolation precautions, specifically for things like measles or respiratory virus infection. And we'll also consider whether we should inform public health regarding the possibility of any communicable diseases that warrant public health intervention or assessment. It's sometimes can be a challenge once we engage public health, but they can be very helpful, especially when we're concerned about potential group exposures or additional exposures to other individuals in the community, patients who are living in congregate settings, or if we're worried about an outbreak. So again, here are the key points to our history or evaluation of a patient who's developed illness after travel. So again, travel history is the key. Did they receive pre-travel advice and did they follow it? An exposure history, detailed chronology of their symptoms, general physical examination, routine investigations with some targeted evaluation depending on the epidemiology where they've traveled and their symptoms, and the recommendations we're going to provide. And as I leave you now, I just wanted to share a few pearls passed down to me from an absolute legend in tropical medicine. Also a teacher, a mentor, and former colleague, Dr. Jay Keystone. And I'll say, to be honest, I feel that almost anything that I've said here that's of value is really been imparted to me by Jay. So here are a few things to say. The first is if a patient has traveled to a malaria endemic region, the differential diagnosis of fever is malaria, malaria, and malaria, until proven otherwise. Even if you've diagnosed something else, still consider malaria until you've ruled it out. When you're taking history, ask what people did on the travel, not just where they went, because that's the meat of the exposure history. Incubation periods are our best friend for diagnosing a number of conditions, or more importantly, ruling out other conditions. So some conditions have a very short incubation, like dengue, leptospirosis, or rickettsial infections. Some of them are more intermediate, and some can be quite extended after someone's left an endemic region. The most important diagnostic test is a good travel history. And I think that's important. Rather than just thinking about the boxes to tick on our lab investigations or what to click on the computer, a detailed history will often be more helpful in making a diagnosis. And then the last thing is don't forget the common things. So, someone who's traveled to some part of the world and comes back with a fever can still have pyelonephritis or a UTI or a typical upper respiratory tract infection. And then we can consider the travel-related illnesses as well. Here's a couple of resources that I found quite useful. The first is from the CDC, a general approach to the return traveler, and also a Canadian guideline, CAT-MAT, Fever and the Returning International Travel, initial assessment guidelines. Both are quite good as resources and references. So that's all for now. I'm Dr. Paul Bunce, and I want to thank you again for watching. Please share any feedback you have about this particular session or FirstcallID as a whole. If you like what we're doing or find this useful, please share with a friend. Take care.